All right. Welcome, everyone, to another episode of our chapter podcast. Today, we are here with Dr. Oden, and we'll be talking about puberty and things to expect before a first period and all of that good stuff. So, we'll start with just having Dr. Oden introduce himself.
Hello, thank you for having me on. My name is Jon Oden. I'm a pediatric endocrinologist. I have about 25 years of experience, and I'm working currently with Arkansas Children's Hospital.
Wonderful. Thank you. So,
Yeah.
just to kick us off, what are the normal processes and signs of puberty for girls specifically?
Um, I guess in both genders, there is a timing mechanism within our brain that sets off a series of events that creates an environment for the body to experience surges in certain hormones, especially specifically for females, estrogen. Though I guess it should be said that both males and females create both types of hormones, testosterone and estrogen. It's just the variety of level that we experience. Males, of course, have more testosterone. Females have more estrogen. This tends to occur in females as early as 8, but it usually occurs in the majority of females around the age of 10. The initial signs, sorry, I should have gotten to that first. The initial signs for females is breast budding. So tiny little nubbins of tissue right underneath the nipple on the chest. Sometimes families can view that. For males, on the other hand, it's much more difficult. And most boys couldn't tell you at all when they started puberty, because that's not a sentinel event in their life. And that is the increase in size in their testicle. A lot of families come to see us concerned about puberty specifically because of specific hair growth, like underarm hair or pubic hair, and that is typically not puberty. That's a different concept altogether.
So I remember in my sort of fifth grade health class, they separated the boys and girls to talk about puberty and, reproductive health and things like that. And I
Right.
remember our teacher asking us girls when our mothers started their period, to sort of get a better idea of when we could possibly start our own period. So
Right.
what role do genetics and sort of family history play in puberty and what to expect?
Well, it is a very common question for us to ask our families, like, when did mom start their cycles? And that kind of gives us a sense of how to reassure families that, hey, she may experience her periods earlier, slightly earlier than mom, but it's going to be around the same age. Now, specifically, there are several genes that are associated with both early and late puberty, that have been identified, but the average age of initiating menstrual cycles in the aggregate of our population really hasn't changed much. In some of the groups of our community, there has been a slight change from about 12 and a half at first period, or which is called menarche, to about 11.9 years. And that's in like African American populations, some Asian populations. So very specific populations may be experiencing slightly earlier menarche.
And that was going to be my next question because I know there's a lot of talk online and in the news that parents are concerned that children are starting puberty earlier and getting their periods earlier from like middle school to elementary school now.
Right.
And so you kind of covered that. So for those who are experiencing puberty earlier, what could be potentially causing that?
Well, for the most part, in females specifically, we find absolutely nothing. So there's just this theory that there's a difference in the timing mechanism. The way this timing mechanism is set, theoretically, is by a brief spurt of hormones in the first year of life. That is called kind of a quote unquote mini puberty. And so when that timing mechanism goes off, however it is controlled, however it is set, um, that is when we see signs of puberty. Okay. Did I answer your question? I feel like I didn't answer.
No, you did.
Okay, good.
That what you mentioning, sort of hormones in the first year, it made me think of, some baby girls have a period.
Yeah,
Not really, but kind of.
right.
Is there any correlation between the baby girls that have sort of that period aspect in their first year and what puberty could look like for them?
That's a great question. None that I know of, none that I've ever read about. Not really sure it's ever really been looked at, but you're right. There are some females who are exposed to higher levels of estrogen inside mom, and their uterus builds up a little bit of a lining, and then they have a little bit of not only breast tissue, but they can have a little bit of menstrual bleed. Likewise, at the initiation of puberty, a small number of girls can experience what's called precocious menarche, which is just a couple of cycles off and on for a brief period of time right before puberty starts or right as puberty is starting. And that alarms a lot of people, including, endocrinologists, because, we kind of get involved with this story of, hey, she started her period last month, had another period this month, what's going on? And we delve into it a little bit with blood work and x-rays and don't tend to find a whole lot, and that's our explanation of, well, this is probably just a benign variant of execution of puberty.
So that is a perfect lead into my next question about what should parents be aware of with precocious puberty or early puberty for both boys and girls.
um um that's a great question, and I've been thinking about this one for a while, because what should pediatricians be telling their families when they see some early development? I think in general, for females, we're looking for a pathological cause. We're looking for something that really needs to be addressed. And because puberty is managed in our brain with our pituitary and our hypothalamus, we are, of course, going to first go towards the evaluation of the brain. Where is puberty coming from? So we measure things like estrogen levels, we measure hormones like LH and FSH, to determine if this is central or brain, or is it peripheral, like McCune Albright, in which case the ovaries are creating too much estrogen with no control whatsoever. So that's kind of our first step. Um, and so for parents, when we're thinking about that process, we really need to kind of be clear with them what the chances are. So in females, the chances of finding something like pathological, something that really is concerning, is very low, especially if puberty begins after the age of 6. Before the age of 6, we see more and more concerning issues the younger a child is. So a 3-year-old with breast development and other signs of puberty is much more concerning than a 7.5-year-old young lady who has started to have breast budding. The 7.5-year-old more than likely could be completely normal, and we don't even have to treat. But the 3-year-old, we probably would have to kind of move forward a little bit more carefully and specifically to evaluate that kid. The second thing for parents of females with early puberty is that when we finish our evaluation and we determine that the puberty is early, we think about the overall effect of a final adult height. So if you're a 6-year-old young lady and you're going through puberty early, you will see an improvement in height. And sometimes families are like, wow, everything's going to be great because she's growing really well. She's taller than everybody else in her class. But the cost of that is an advancement in her growth plates, so that those growth plates will fuse sooner than her peer group and cause a reduction in her final adult height that is significant. And that's why we use medications like GnRH agonists, like Lupron, to slow
Mhm.
puberty down and kind of protect those growth plates. For males, on the other hand, we do MRIs in every single one of them, especially when we diagnose central precocious puberty. There are other causes of peripheral puberty that we probably shouldn't get into in males because they are very, very rare. But when we diagnose central precocious puberty, we do MRIs in all of them, because more males with early puberty or enlargement in testis um, have pathological causes of that process than females. And I think that's a challenging conversation that we have to have with our families. But in the end, it's important to have them kind of briefed on what our concerns are so that things get done in a timely fashion. The treatment of it, however, is the same. Not necessarily the organic cause of puberty in males, but or precocious puberty in males, but the underlying treatment of precocious puberty is the same. We usually use a GnRH agonist.
And so we talked a little bit about parents. What can pediatricians do in their own clinics to help those who are experiencing precocious puberty?
Well, so as I alluded to before, there are somewhat of a misunderstanding about what puberty truly is, right? I mean, as endocrinologists, we deal with this every day, but as pediatricians, they don't. And if you don't really remember it from your residency program, if you didn't, rotate with an endocrinologist, you might not ever have that experience. So one of the things that pediatricians probably should verse themselves on, or at least touch base with an endocrinologist about, hey, what should I be looking for, is the prime thing. So defining puberty is a very important thing. There are many things online that they can look at, like Tanner staging documents that show the pictorial view of the stages of puberty. That is not well known in our pediatric community. I'm not saying they should know that. That's not something that they see. But what we also see is a confusion between what's called adrenarche or pubic hair development and gonadarche or true puberty, central puberty, which is the development of breast budding, and in males the enlargement of testes. So being able to do that is paramount, because counseling families on what they should expect from a specialist like me is sometimes kind of railroaded. It's not quite transcribed well, and parents come to us very, very concerned of of their 6-year-old who has a strand or two of pubic hair, and they think the kiddo's going to have their cycles, their periods in the next couple of months. And we're like, no, that's not exactly how this happens. So I think pediatricians would be well served to kind of either touch base with one of our team and go over what is puberty and what is adrenarche, ask us to come give a talk, ask us to send a PowerPoint presentation that we give to residents, etc. We're happy to help in any way to make that transition a little bit easier.
So we've talked a bit about early puberty. Is delayed puberty and delayed periods just as common? I know we can see it a bit in girls who are very athletic. You see it a lot in
Mhm.
gymnasts or swimmers who get
Right,
periods at 15 instead of
right.
11. So how common is that?
It is actually more common than early puberty, but you have to take that into the context of what we're speaking about. So
Mm.
like typical delayed puberty, the most common cause, more than likely, is something called constitutional delay in growth and puberty. But that is diagnosed more often in males than in females, whereas precocious puberty is diagnosed more in females than in males. So in our male patients, it is we see these kids every day. They have a slightly delayed onset of puberty. So instead of experiencing the initial signs of puberty at 10 or 11, these kiddos may not see the changes that they are expecting from their peer group until 13, 14, or 15. And so that is a very challenging diagnosis to make, because essentially it's a diagnosis of exclusion. We run through our series of tests that we do on these kiddos. We try to normalize those values based on their physical exam, what their Tanner staging is, and then we look at something called a bone age. With those boys, however, because it's a diagnosis of exclusion and because there's no specific treatment, it is very frustrating for families and for parents, especially in kids who are sports oriented, especially for our boys who want to play football. And they're not going to be as hefty or as developed or as fast, or they don't have the endurance that all of their friends have because of their stage of puberty. And honestly, we try not to interfere with Mother Nature as much as possible. So it is a very difficult conversation to have sometimes with our families, um, in order for them to kind of understand what our process is.
Are there other signs that a child is experiencing delayed puberty, or is it just, their voice isn't getting deeper, their period hasn't come? Are there other things to look out for?
Well, so true delay in puberty, for males, we don't get too worried until the age of 14. And so the
Okay.
first sign would be enlargement of testis. And for females, it's around the age of 13 for breast budding. And if
Mhm.
they haven't had a cycle by around age 16, if they've had all the other signs of puberty moving forward.
Mhm.
Um, that's a generalization.
Mhm.
So if they have not had any of those signs, we get concerned at those ages, and then we kind of set off down the path of, can we detect any evidence of pituitary abnormalities so that they don't have this LH and FSH surge to generate gonad responses,
Mhm.
or are they resistant to a hormone, or are their gonads not functioning well? Primary ovarian failure or premature ovarian failure, sorry, is not that uncommon in some of our female patients. And that's something that we need to be aware of because autoimmune disease is now kind of a real tick
Yeah.
mark for us as endocrinologists as the use of Tzield for type 1 diabetes is coming online. We're starting to screen for a whole lot of autoimmune diseases, and premature ovarian failure is one of those things that we need to be aware of.
I think we found our next podcast topic with you is going to be all about autoimmune diseases. I think that could be a really interesting
Yeah.
one.
Well,
Um,
screening for type 1 diabetes is a big, big topic now. And we're starting to ask our general pediatric group
mhm.
to begin screening general population, not just high risk population. It's not an approved recommendation right now, but we're working on getting that through the AAP.
Mhm.
Um, to be approved and to be recommended at specific ages. In the Northwest Arkansas, our general pediatric clinic has been doing some screening for us, and we've picked up on around 60 kids who
Yeah.
are antibody positive for type 1 diabetes and causes those kids to be at high risk, and they need to be followed very carefully. And the
Mhm.
end result is, can we use these medications that can we use this medication that we now have, Tzield,
Mm.
or I guess I should say teplizumab because Tzield is the brand name, but can we use teplizumab? Um, or if we can't, can we provide education for this family so these kiddos don't just get missed for months and they get sicker and sicker and sicker with type 1? So, absolutely critical. I would love to do a podcast about any one of those things. So, yeah, check.
Perfect. So is there anything pediatricians, in general practice can do to help um the kids and family or the parents for those experiencing delayed puberty, or is it just, another referral to you or an endocrinologist?
Um, I think, first and foremost, have a very detailed and specific physical exam.
Hmm.
We do get a lot of referrals for early or delayed puberty mostly, with no physical exam on them at all,
Hmm.
at least in the recent past. And so you have to have kind of an up-to-date physical exam with Tanner staging on that document for us to kind of interpret what's going on. Um, the other thing that pediatricians may think about doing is supplying these families with some sort of psychological support, social work help, counseling help. If we think about it in terms of what these children and these families are going through, it's not a small event. And
Yeah.
I have seen the faces of our kids that walk through, in telling a young lady who is 6 or 7 that she has something wrong with her is a challenge. We try to, get our social work team engaged as much as we can, but we have our resources are relatively limited. So having a pediatrician that is cognizant of that and able to help at least in some way, to bring those counseling services, social work services, psychological services to bear, that would be great.
Yeah, I can imagine that sort of pre-adolescent, pre-puberty, puberty phase is just hard enough already for a
Oh
kid
yeah,
and for families
yeah,
that adding on something quote unquote wrong is just
yeah,
another thing to have to deal with during a
yeah.
really
All
hard
the
time.
not only the psychosocial and the emotional, but think of these children are placed in a subspecialist office. It's kind of strange. We have to do exams that are uncomfortable for them. Bless their hearts.
Mm.
and the blood work and all the radiology that we have to do, the bone ages and then the MRIs, it has to be very frightening for them. So yeah, I think one of the bigger concepts for us as a medical community is how we bring an adequate amount of psychosocial support for these families together, because we're not going to be able to do it alone. Our program certainly doesn't have enough of that to spread across all of our kids with chronic disease.
Yeah. So my last question that I have is, and this is kind of a big one, do you have any advice for parents of, elementary age children that are about to hit puberty, especially if it's, like the only child, the oldest child, the
Right,
parents haven't gone through this before?
right.
What sort of
It's
advice do you
tough.
have? Yeah.
You mean like for normal puberty, of course, right?
Right, right.
Yeah. So I mean, I think patience is is the biggest one.
Hmm.
And we get asked this question too a lot of times in kids that we're not following for puberty. They're like, he or she is showing signs. How do we address that? And
Yeah.
as a father of three girls myself,
Mhm.
really, it's patience,
Yeah.
absolute patience. And you're going to see some changes in behavior. You're going to have to be able to mitigate that. And there are books on the subject that my wife went and bought, and I think it was Love with Logic was one of her favorite ones, that helped her constantly in the battle of the behavior for kids with just experiencing the angst of puberty.
Yeah, my dad also had three daughters who were all teenagers at the exact same time.
Yeah.
And I think patience is key, and
Yes.
just understanding everyone just take a breath. We'll
Yep.
get through it together.
Yep. That's right. And it all gets better. I mean,
Yeah.
one of my kiddos was flagrantly disobedient.
Mm.
Um, uh, Beautiful child. She's great, and as she has matured, all of that ironed itself out. And
Hmm.
so, even though we may feel like, hey, this is a lot, and oh, this is horrible, um, it does get better as puberty settles itself out. The other thing to do as well is if they feel like this is not in the normal,
Mm.
there are counseling services that are available in their local community, which may be helpful to kind of mitigate some of those things, especially at school. So, school counselor, a trusted teacher, those kind of things, they may want to have, some place where the child can kind of speak their mind. And that is not uncommon in our population, I don't think.
I totally agree. Do you have anything else you'd like to add? Any last minute comments that you'd like to share?
No, I think from the perspective of a subspecialist in pediatrics, we enjoy the relationship that we have with our general pediatrician colleagues, and would ask that if they have any questions, to please reach out to us. We're always open. They may not get us at our best time, and we may be grumpy on the other end because we've been on call for 160 hours straight. But that being said, I think it is important for us to have a communication line open so that we can talk about things like, do you need to send us a kid who is 8.5 years old and just now is starting to have breast buds because mom is worried? The answer to that usually is going to be no. Should I send a kiddo who is 3 and has breast budding? And yes, that is there, and then we can kind of tell them, kind of direct them on what they need to be doing, and then also we can on our end provide them with a more appropriate appointment.
Well, perfect. Thank you so much. I really appreciate your time
Yeah,
uh,
thank you.
today. And I think this will be a great conversation for both pediatricians and parents to listen to.
Yeah,
Uh,
great.
and we will be sure to have you back on.
Oh, please do. Yeah, I look forward to it.
Thank you so much.
Take care.